Hello, my name is Dr. Brian McClelland at www.dental-marketing.org. Today, I'd like to review an article titled Multisystem Complications Following Endodontic Therapy, or what I like to term root canal gone bad. The authors were Blount and Lesser, and it's found in the JOMS, which is the Journal of Oral and Maxillofacial Surgery, page 527 to 530, year 2012. Essentially what we have is a 54-year-old man who underwent endodontic therapy on tooth numbers 21, so the lower left first premolar. Past medical history was significant for diabetes and hypertension, and his diabetes and hypertension were only treated with herbal supplements. After no antibiotics were given after the endodontic therapy, where the pulp was removed, and a fill was to be done at a later date. 2 days later, the patient was referred to an oral and maxillofacial surgeon for extraction and incision and drainage of a vestibular space infection due to worsening of signs and symptoms. 2 days later, the patient went to the emergency department with worse facial pain and swelling. At the emergency department, the presenting glucose was 417 milligrams per deciliter. His hemoglobin A1C was 7.9%. Now, the goal for diabetics is to keep their A1C less than 7%. His white blood cell count is elevated at 14. The patient had trismus, swelling in the left buccal and submandibular space. A CT scan showed a left buccal, left submandibular, submental, and sublingual space infection. The following day, the sublingual space was firm and tender and no improvement, so the patient was taken to the operating room for an incision and drainage of all the involved spaces from both an intraoral and an extraoral route, as well as extraction of the now mobile tooth numbers 20. On postoperative day 1, the patient reported improvement. The next day, there was a sudden onset of chest pain, increased respiratory effort, and saturations in the 70s, and that's 70%, and the patient was orally intubated due to respiratory failure. The blood cultures were taken at that point, and they were positive for MRSA, or methicillin-resistant Staph aureus. On the fifth postoperative day, the patient's drains were removed, and the patient was then trached due to persistent ventilatory issues and signs and symptoms consistent with ARDS. High pressure and high concentration oxygen were given for 2 weeks, and the patient during that time developed bilateral pneumothoraces and had bilateral chest tubes placed. The patient then developed acute renal failure and had a dusky right first finger and second finger of his right hand, suggesting septic emboli. Aspiration of purulent sputum was suspected as the cause of his pulmonary issues. This is a different mechanism for his respiratory failure than, or another alternative reason for his respiratory failure. The patient was extubated over 3 weeks, and it was noticed that he did not have full movement of his extremities, and a CT and MRI of his head showed a septic emboli stroke. The antibiotics that the patient was on was vancomycin and piperacillin and tazobactam. On hospital day 53, so that's after 53 days of being in the hospital, bright red blood was noted in the trach site, and the patient desaturated into the 40s, and a large clot in the trachea was removed. Bleeders were cauterized, and the patient was transfused 2 units of packed red blood cells. The patient was eventually discharged and has since made significant improvements considering the degree of brain injury from his CVA. So the discussion with this, over 100 million people worldwide are estimated to have diabetes, and this complicates patients' recovery and care, and the incidence of diabetes is increasing. MRSA has rarely been reported in odontogenic infections, thank goodness, but the incidence may be rising. Personally, I think that an IND should have been done on the day of hospital admission, and this patient may have had an entirely different course if done. With trismus, I have to wonder if a space was missed with the initial incision and drainage / diagnosis. It is possible to get trismus with the spaces described, but it's generally mild, and this report does not quantify the amount of trismus that the patient has. With severe trismus, I would expect a space such as the pterygomandibular space or the submasseteric space, maybe the infratemporal space, that will be involved, irritating the major muscle of mastication leading to the trismus. The patient is a diabetic, but his hemoglobin A1C was only mildly elevated, which is surprising considering he was only self-medicating for his diabetes. So this case report is a great reminder of how simple things can become very complex very quickly and require a team to help our patients. It also reminds us that sometimes there's significant morbidity and sometimes even mortality secondary to dental problems and dental issues. Well, thank you for tuning in this week, and I hope to see you next time. Again, my name's Dr. Brian McClelland at www.dental-marketing.org. Thank you.